to hover right at goal over the last 4 months, varying from 77 to 74, with our most recent month at 75.2% in June. If we go to the next slide, we'll see some of the contributing factors. So first is nursing domain, so communication. And we had 3 months of a decline and saw a bit of an uptick in June from 63 to 67%. So we're hopeful to continue to see that trend in the coming months. A lot of that's driven by reinforcing our standards of behavior, doing that, leader rounding, sitting with the patients. For the unit leaders, we did see a 10-point increase in nurses. Nurses explained to you in a way you can understand, as well as treating with courtesy and respect. We saw nice increases month over month. Next slide. This is our environment of care. We did see a nice increase here as well, May into June, from 55% to 60%. Again, very much driven by visual management for EVS on room turnovers. They have some visual guides in terms of what the room should look like, so they're really sticking to that. And then leadership rounding as well, we think is contributing to that increase. If there's any questions on patient experience, we'll shift to clinical documentation. We see here surgical CMI dropped a bit from 3.1 to 2.9. A lot of the work that we've been discussing has happened in May and June, so we're very much anticipating to see what happens in the next few months as the data updates. Medical CMI has been relatively flat at 1.23. Next slide. We saw a bit of an improvement in our observation percentages from 30% down to 28%, again, engaging with our clinical teams and interdisciplinary rounds, trying to right status our patients in real time. Next slide. And our mortality observed over expected. We remain better than expected, which is nice to see. We were at 0.85 up to 0.96. Again, kind of two areas of focus there. Reviewing our true mortalities, looking for opportunities for clinical care, but then also improving our documentation so that our severity of illness is accurately reflected for our clinicians and the patients that they're taking care of. Next slide.
Can I excuse me, Dr.
Yes, please.
Can I just interrupt you for a quick second? The period that we're looking at right now, is this June 1st when I was resident? Is this inclusive of that time period?
No, so right now the data is up through April. So.
Oh, okay.
Yeah. So we'll see June somewhere in mid-fall, I think.
Okay.
Or July, sorry, July.
It's usually between 30 to 90 days that you see the lag.
Yeah. And this is the slide I'm probably most excited about. We continue to see improvements. Great team effort in sepsis. Last month we were at 68% step 1 bundle compliance. We're now up to 73%. Our rolling 12 has improved from 17% back in April of 22 up to almost 44% in this April. A lot of work continues to go on around that through process redesign as well as how we're using our system. Reflex lactate was our most common fallout for not complying on the abstracted cases. We're putting in a reflex lactate now within the system. So if they have an elevated lactate on the first draw, it'll automatically order the second draw. And had we had that in place this month, that was again our most common fallout, we would have been at 93%. Next slide. This is our hospital-acquired C. diff volumes. We were at 43 cases in 2022, and through June, so halfway through the year, we're at 11 cases. So if we assume a linear rate, we should end up around the 22 mark, which will be about a 50% reduction year over year. Next slide. Our readmissions took a bit of a bump. We did see an increase in our 7-day readmission. It went from 2.2 to 4.4% month over month. The team is looking into some of the contributing factors, but we did do a discharge value stream analysis last month. I referenced it in our discussion last month. It was coming up in the following few days, but we did identify a few process opportunities to kind of solidify how we transition patients out of the hospital and back to clinic. So more work to come there. Next slide. This is our EDAC, so excess days of acute care. So again, kind of raising the bar. It's not just inpatient readmissions. This is any acute utilization post-inpatient stay, so observation and ED visits count as well. We see a nice downward trend from January through March, from 24 days down to 16. Next slide. Throughput, again, a very nice success here through process redesign back in December. We saw a consistent decline, and we're sustaining there at around 3%, basically moving the clinicians towards the front of the ED, so there's less of a wait between triage and seeing a clinician for assessment. Next slide. This is our throughput. So this is variance to geometric mean length of stay. We did see a nice downtrend towards goal from 2.3 to 2.0. Part of that, I think, is our EVS team has really focused in on quicker room turnovers. We've seen this year a decrease from 132 minutes down to 99 minutes, so some really great work there. Next slide. We have our last two HEDIS measures. This is breast cancer screening, a flat May to June, but right almost at goal at 57.6%. We continue to work on clinic processes and improvements there. Next slide. We have blood pressure control, kind of again, a steady increase. We're up to 58% there. And I'd be happy to take any questions.
I don't have a question. I would just compliment the LWOPs over the last 5 to 6 months. I think that's a real plus.
Yes, excellent work with our ED team.
You look at the numbers prior to that, going back to like August. I mean, you're talking about patient satisfaction and commentary in the community.
Yeah.
You know, people would love to tell stories about sitting in the ED for 5 days, and, you know, exaggerating. Yeah, this is good work. So kudos to you, Israel, and the team.
Great team.
For making that reduction.
Thank you.
I actually have a question. I'm looking at slide, I guess they're not numbered, but it's the CMS
Slide 8.
Slide 8, okay.
The sepsis.
Yeah, I mean, that's really dramatic improvement. Is there anything we could learn from by how you go about with that type of improvement to apply to other areas to have the same type of dramatic impact?
Absolutely. So it's actually an approach that we're trying to take in a broader sense through the organization. We did what's called a rapid improvement event back in December, and that really got the front lines to sit down, our nurses, our doctors, our lab techs, to really sit down and kind of talk through what is current state, and then have them identify, you know, what things are barriers that they're identifying to do their job more effectively, and then have them offer up solutions to the leadership team, and then it becomes our job to help implement that. So that was one of the key drivers, and that's also where, you know, using the data, we're seeing these opportunities with repeat lactate and those types of things. How do we then design systems behind that to support our team so that they're got to remove that human factor where they have to remember to do something extra. The system does it for them.
No, that's great. Thank you, and congratulations.
Thank you.
Yeah,
I'm sorry, Dr. Chair Bott has a question, please.
Yes.
thank you. I would just was going to go in the direction that both my colleagues, Director Mori and Dr. Garza went. I think just congratulations and how we can apply some of the learnings here. One of the questions on the sepsis piece is, are we using analytics to get in front of those that might be deteriorating? Is that happening today, or no, that, you know, aren't at sepsis yet but could be at high risk for sepsis?
So we are. There's an alert in Cerner that uses essentially logic to identify patients that are meeting the early identifiers for the bundle criteria.
Okay.
And interestingly, though, it fires very often in our ICU, and we've done a separate project that actually showed improvement by turning off the alert in the ICU. We actually had improvement in mortality as well as outcomes and bundle compliance by kind of removing, in that sense, we're thinking in the ICU it was kind of becoming alert fatigue, where people would see it and say, well, this is probably not sepsis, or it alerted the last 3 days, kind of weren't really watching it there. So kind of a two-pronged approach, right? Really leveraging it in the places where it's going to be meaningful in early recognition when they show up at our front door, but then also when it's kind of creating a bit of noise to maybe kind of set that aside and use some clinical acumen to decide.
Great. Yeah, and then thank you. And then I'd be curious, yeah, to understand why readmissions have evolved, you know, have shifted. So we'll look forward to that.
Okay, thank you.
Thank you.
Thanks. All right, we'll move to item 3B, regulatory and accreditation updates, reviewed by Ms. Cynthia Fish, Director of Quality, Regulatory Affairs, and Accreditation.
Thank you so much.
Sure.
Good morning.
Good morning.
All
Good
right,
morning.
our regulatory update. So we'll start with Providence. So as you see, we still have our GAP survey listed up here because they are still expected to come this year in 2023. Again, that is the laboratory survey. We do have an additional mock survey that's being planned very soon to occur at Providence Hospital. We continue to be in the triennial window for the survey, so that can happen anytime. We're thinking maybe closer to the fall, but in lieu of that, we are doing random tracers. We're doing those weekly across many different areas. The mock findings from the previous mock survey are still being reviewed on a weekly basis with the corrective actions and also their compliance and their audit data being shared. And then finally, we also continue to do have a gap analysis readout weekly, so the chapter owners are sharing their compliance where they are with the Joint Commission standards. Moving to Stroger, I wanted to share that in June we had a 2-day Joint Commission extensive complaint survey. It was very broad, but I'm so pleased to say that there were no citations and no findings, no recommendations given. We do have a mock survey also planned to be performed at Stroger. That'll follow Providence, so maybe closer towards the end of summer or moving into fall. But we are still meeting with the chapter owners also to see where are they in their compliance with the last triennial survey. So are they still compliant? And then finally, with the health equity certification, Cook County Health is beginning our journey. I was able to get a sneak peek at those standards that had just come out on July 1st. There are 13 standards. I just wanted to share that when I take a look at which we are beginning to drill down, not only are we looking at opportunities, how do we improve the care with the patients and the communities we serve, there's also an opportunity in one of the standards listed where we are looking internally of how are we going to identify opportunities to improve health equity from our staff and leaders. So that's quite interesting. We're going to be looking at the diversity of the organization, looking at the languages spoken here, and also to look at any perceptions or incidents of discrimination and bias that's been experienced here by staff and leaders. So I'm interested to get started, but I think that's a great opportunity, again, not only to look how do we improve care to our community, but how do we continue to improve our processes and with our staff and leaders.
Thank you. Any questions?
I have a question with respect to the healthcare equity certification.
Mm-hmm.
Is that in concert with the regular triennial survey, or is that a separate process altogether?
Yes, sir, it's a separate process. So this sits under Joint Commission. It's considered a certification. Like many of the disease states, as we have primary stroke certification, this is health equity certification. The triennial survey is considered the accreditation. It's done every 3 years. But I will share with you that there are some health equity standards that we've already, and I believe we discussed that last time, looking at data, how are we addressing certain disparities here, that are included in that triennial survey for the hospital survey. So there is some intermingling. I do believe this brand new certification, it's brand new to Joint Commission, again, just opened July 1st for me to be able to look at the standards. Really drill a little bit more into, as I said, even looking at staff and leaders of an organization and what are we doing here to improve health equity. So it shares some data, but it is separate.
Yeah, what I would add is I think the overall survey has some elements that really serve as the basis that they want to make sure every organization has. Mm-hmm. And then if your organization wants to go further and say we are prioritizing this as sort of a center of excellence, then they have that higher standard. So we are making sure that we're meeting the base level standards that are required as part of every hospital. And then this is an additional certification that we pursue that says that we want to go beyond the efforts that are required and really demonstrate that we are performing at the highest levels and standards and incorporate the best practices across the country as a health equity institution. And so we're excited to be one of the first to do this.
So we're targeting the higher
The highest
certification.
standard, yeah.
Well, going forward in the future state, will there be a life cycle for the healthcare equity for the office?
It's usually a set number of years. So is this one 3?
2 years.
2 years.
2 years?
Once you receive the certification, because they will come out and do a survey, and we'll share and showcase our great work. Once we receive that, then it would be on a 2-year biannual basis then.
And I will say, that, using my school teacher's adage, it is harder to maintain the A than to get the A. So once you get it at first, then they come back, and the maintenance is the hardest, because then you have to prove that you're meeting those standards in real time. The first one says that you have the structure. So as they come every 2 years, then you have to prove that you're living up to the commitments that you made.
Your sustainability.
Director Harrington.
Yeah, with the recent Supreme Court decision that you can no longer use race as a barometer for admissions in colleges and universities, they've been discussing this idea of a more holistic approach to diversity. And I was wondering, has that caused us to take a look at how we define diversity moving forward in terms of a more holistic view and looking at individuals and classes and groups of people that have been underserved and historically underrepresented, as opposed to just looking at race?
Sure, I can answer that. So part of what we have done in most of the programs that we have or scholarships that we had, it really looks at underrepresented individuals, and that has socioeconomic applications as well as different types of standards. And so what we are doing, as most institutions around the area are looking at, is that we are making sure that all of our programs that are built to ensure that no one is left behind in healthcare, and that no one extends to everyone, whether it's regardless of socioeconomic status or other indicators that would lead them to be traditionally left out of processes, are incorporated. And so the broad approach that most, and we have worked with our academic partners as well to get that language, as we are also a teaching institution. So the first programs and passes that we are looking at is in coordination with our GME requirements and our processes, and those always refer to underrepresented individuals, and that includes socioeconomic standards, first to go to college, first to go to education, living in poverty areas, certain zip code statistics. And so it is a broad scope to really capture that someone is left behind through traditional programming, and that's a broad inclusive category for everyone that should be able to meet any standards that were recently passed. And so we're working across the spectrum, but we always look to it as diversity, equity, and inclusion, including everyone's at the table, and that is broad in its approach and application.
Thank you.
Great questions. We're excited about our journey.
It'll be interesting as we're going forward, as you said, to be able to look at, not that we're talking about combining, but just that we all part of Cook County, and to just sort of juxtaposition, you know, the county equity task force and what you all will be developing here in terms of the equity initiative. Since we're serving residents of Cook County with the county government or CCHHS, it'd be, I think that something you might want to consider.
No, absolutely. We look to work in partnership, and we do have our Chief Equity and Inclusion Officer who coordinates with the county's equity programs as well to make sure we're in alignment. And then we're applicable. We work with our educational partners and with the health requirements to make sure they're all coming together in a powerful way. So we'll keep updating and working with both together.
I would appreciate having it, if you wouldn't mind, the standards going forward. I would love to be able to see just eyeball those.
I have them right here, sure.
Just send them to me, email. And
Absolutely.
We'll submit them to the committee and make them.
And get them to you, yeah.
thank you.
Okay.
All right, I believe Chair Bott has a question.
Yep. Thank you. And before I just ask the question, I just want to express gratitude to you, Dr. Garza, for stepping in here, as well as Dr. Story. I think the thing I want to lift up that's important, which makes this of even more importance, is that it's not just a leadership standard, but it's become a national patient safety goal. So the Joint Commission's elevated it, you know, to the context of patient safety, so we can look at our work and metrics within that lens of equity, you know, or quality and safety through an equity lens. But I think it just you know, it speaks to that, along with other regulatory headwinds that are supporting health equity in the care delivery environment.
Correct, thank you. Yes, that was added to the National Patient Safety Goal chapter, which is part of the accreditation every 3 years of an organization. Absolutely.
No other questions. Thank you, Cynthia.
All right, thank you.
Yep.
Thank you.
Okay, we'll go to item 3C, update from HRO work group on throughput, and that'll be reviewed by Dr. Pyarko and Dr. Raymore.
Good morning, directors.
Good morning.
Morning.
My name is Dr. Pierko, and together with Dr. Patricia Rayburn, we lead newly formed HRO work group. So it was formed at the beginning of the year, and since then we've been trying to create a structure, address metrics and tactics to improve throughput in our organization. On the slide, you can see our organizational chart. I would like to make a comment that our current project sponsor is Ms. Tonika Austin-Catley. Mr. Williams was replaced in the previous month, so I apologize for not updating this chart. As you can see, throughput is extremely complex problem of many organizations, and that includes Cook County Health as well. To tackle this problem, we have created 4 subgroups to ensure that we have focus on various areas of our hospital. So we have operational throughput, inpatient throughput, emergency department throughput, and we have a data support from our HIS and teletracking groups. Next slide, please. This slide shows our big picture work group A3. As you can see, we have addressed 1 or 2 main metrics for all of the subgroups. For emergency department, this is less vote being seen with less than 3% goal, and our stretch goal less than 2.75%, as well as the emergency department arrival to departure time, which is less than 220 minutes, with stretch of less than 191 minutes. Both metrics are CMS rated, therefore we identify them as crucial for throughput operations. From operational throughput, we are focusing on EVS bed turnaround time, as well as transportation of the patient turnaround time. From inpatient throughput, our main focus is on reducing average length of stay. Our goal is to reduce it by at least half a day till the end of this year, with a stretch of more than 1 day. We're also looking at our discharge process and our time from confirmed discharge to actual discharge time, with goal of less than 120 minutes. As Dr. Mikaitis presented in his report, our data throughput is also focusing on variance average length of stay versus geometric mean length of stay, with the goal of less than 1.76 days, with stretch of less than 1.26 days. Next slide, please.
Can I just ask a quick question?
Yes, please.
With respect to the average length of stay currently? You're looking to reduce it by 0.5 days the end of this year?
Yes, that's the goal.
So where are we today? Where are you today?
So today we are around 5 to 6 days. So to be exact, our current length of stay, if I have it. So currently we are around 6 days. So hopefully by the end of the year we can get 5.5, ideally 5 or less.
The color coding on slide number 3, I think I know what it means, but could you let us know?
Yes, so red means that we are not meeting our goal. Yellow means that we are approaching the goal. Green, we are meeting the goal. And gray is that we don't have the data yet.
Thank you.
With regards to, if we can move to next slide. The next 3 slides are representing our detailed tactics to achieve predefined goals. With regards to inpatient throughput, I would like to just mention that we have multidisciplinary teams. We have a number of people who are heavily involved in work of all of the subgroups, and I would really like to recognize their commitment to the case. With regards to our inpatient throughput, we want to achieve reduction in length of stay by first improving our discharge planning. We have already implemented numerous interventions to optimize our interdisciplinary rounds that are being held every single day on the inpatient side. We are working with our residency programs to improve education, communication between providers to ensure that we have a clear plan for all the patients from the time of admission to the time of discharge. We are working with subspecialty consultants to ensure timely recommendations. We have implemented timeline for the recommendations from the subspecialties depending on the time when the consult is being placed. We are looking closely on improving our discharge by noon processes, medication delivery to the floor, ensuring that our patients get the medications quickly and they don't have to wait on the unit to get those medications. Campaign to reduce unnecessary testing, reduce labs, reduce utilization of imaging studies, as well as tactics to increase our testing capacity at our bottleneck areas, which are radiology and cardiology. With regards to our average discharge time, and as you can see on this graph on the right lower quadrant, you can see a great success story. Dr. Rayburn is a part of this success that we were able to achieve, and our goal, and go way beyond our stretch goal, and we were able to sustain this metric. We have opened recently discharge lounge. Hopefully, we will be able to improve these metrics further on.
I just wanted to indicate one thing real quickly so you can know how they work together. So this presentation does use sort of a structure of objective and key results. The top chart that you see there where it says HRO throughput work group, A3, that A3 is looking at the larger objective that we want to get to. And so when you look at those, you're having them broken down by ED, operational, inpatient, and data throughput. And that's the objective. When you look into the second pages that Dr. Preco is going through, those are the key results and tactics. So you have how you're going to reach the larger objective. So they are connected. So when you see, when you're asking what is our current average length of stay, that is articulated in the inpatient throughput, and it has the graph. They're getting ready to do the data, but it's not just the data. We want to actually show the tactics that will reach that desired result. And then the colors are your key results. Are we actually hitting it based on the tactic? And then that connects back up to our objective, which is to read that performance. So we do use objective key results across the institution. This is a great display of the work that the team has done with the project management team, their objectives and their results. And they are leading the group in helping to structure this and bring it forward. So we wanted to showcase that, but just wanted to let everyone know how they flow together and how they connect, meeting from objective level all the way to the key results. And then you heard Dr. Preco talk a little bit about that on how that goes up to our executive dashboards, that goes that we have to hit the CMS measures that we said as an institution. We want to go from a 2 to a 4 to a 5-star. And so then these tactics at that level flow up to our larger objective. And so you see it cascade all down. So it's a great example. Wanted to take a moment, didn't mean to interrupt you, just to also say that in addition to the wonderful work that we're doing managing, the way that you're managing the process as well, and commend you and the HRO team.
Thank you, Mr. Archer. Thank you.
Yeah, thank you. Just a quick question. You referenced consultations. With respect to the work that you all are doing there, are you all defining like a stat consult, 30 minutes, 45 minutes, regular consult within 8 hours, 6 hours? Are you putting parameters around consult?
Yes. So with regards to our consultants, what we have, our approach was to ensure that if the consultation is placed before 9 o'clock in the morning, we will get recommendations for the patient management by noon. If the consult is placed after 9 o'clock in the morning, then we will get recommendations by the end of the day, by 4 p.m. So those are the time frames set for our consultants. Again, this is just a frame to make sure that consultants are following this, but expectations are that communication between providers occurs all the time. We are not waiting. If the patient is ready to go in 10 minutes, we're not going to wait till 4 p.m. for recommendations. We will pick up the phone and say, we are just waiting for your blessing for the patient to go home. So this is the expectation from for all of our inpatient physicians.
I don't want to get too far-fetched here because I'm not a techie, but I'm fascinated with AI, and that's going to be a different world when I'm eating soft food. But will the consult sort of trigger a flag or something in the system once it's put in? If somebody puts a request in for consult at 7:45 a.m., for example.
So currently, it depends on the service. Some of the services receive a pager that there is a new consult in the inbox.
Thank you.
That's what we have already in place.
So it'll be in place. So I don't have to worry about eating soft food. It'll be currently operating that way. That's
Yes.
great.
Yeah. And I do also want to make sure that I commend them for the selection of it. So we also try to encourage our team that we want to see the end result is what we're measuring. So before we could measure that they actually did consult, but did that turn into a definitive recommendation that lets the team take action? So we
Just don't
could,
show up.
yeah, because if we were just measuring that they responded to the consult, that would be great, but then they can take all day before they enter the order. So I commend them for selecting. We were trying to make sure that we're selecting elements that lead and drive that care moving forward. So what you really want to see is that they actually timely inputted the data for the team to take action. And so that's working together. But there is alerts, and Tiger Text, which the board has approved now, also has connections to be able to let us know when certain consults and things are needed to be done. But the result we want to measure is definitely, did they put that in the system so that they can either discharge the patient, move the patient, get them the medication, or get them what they need.
Beautiful. As opposed to just checking the box.
Yeah.
And Tiger Connect is a game changer. I mean, the communication between the various providers improved drastically after we have implemented Tiger Connect. I forgot to mention at the very beginning that what we tasked all of the subgroups was to really perform process mapping of all their respective areas to identify the bottlenecks and find then tactics to break those bottlenecks and make sure that the most crucial processes are not sitting idle. When it comes to our inpatient throughput, our main challenge is oftentimes staffing to ensure that we have enough nurses and other providers to provide the care. If we are closing the beds, we are unable to help the patients move them faster throughout the organization. Our nursing department is doing extremely great job in terms of fixing the problem of the nursing staffing, but this is a national problem with regards of availability of the nurses, and hopefully that would not be our constraint moving forward when it comes to staffing and beds. Let's move to another, next slide, please. I think we skipped one slide for ED throughput. Can we go back, please? One more?
One bit before it.
Thank you. With regards to our emergency department throughput, as I mentioned, we are focusing on reducing left without being seen and our ED arrival to departure metrics. What we're trying to do is to make sure that we have a physician in our Dr. Quick area from 9 a.m. to 9 p.m. every single day, and that proves to be a successful intervention. We want to make sure that we sustain this less than 3% left without being seen moving forward. We are also improving the triaging process. We are reducing the number of questions that are being asked for the patient, tactic pull to full. So whenever patients are waiting in the ED waiting area. We are trying to get them to clinical side as quickly as possible. We are creating internal waiting rooms. So when the patients are already moved to emergency department green, that's where they feel like they're being taken care right away. We are working on the new weekend staffing model, improve provider efficiency, improve discharge documentation, and one of the toughest things to do is to really change a culture, but we are on the right track. And as you can see, our left work being seen improved drastically over the past year. We are working diligently on the median time from ED arrival to ED departure, and you can see this good trend. We are moving towards our predefined goals. Next slide, please. And one more, please. With operational throughput, our two main areas of focus right now is the turnaround time for transportation and cleaning of the inpatient beds. We have, as you can see on the graph on the left lower corner, end of the third and fourth quarter of the last year was quite difficult. It was related to staffing issues. Currently, we are on the very right trend. Currently, back in April, our turnaround time was 50 minutes. Our goal is less than 37 minutes by the end of this year. We have improved, so we have changed some of the tactics related to patient transportation. There was another shift created, 11 a.m. to 7 p.m. for those peak hours when we are having the most patients being transported. We are working on tracking efficiency of transport technicians, as well as how many jobs per hour they perform, and utilization of technology, including teletracking for at the employee level, so people understand what is expected from them. With regards to EDS better turnaround time, even though we can clearly see that there is a downtrend towards the goal, there are some issues with the staffing as well, receiving the badges for the staff. Those issues are being resolved as we speak. So hopefully we continue to see appropriate trend. And finally, the last slide with regards to our data throughput and our average variance for geometric mean length of stay. The focus here is to really improve documentation and improve our discharge planning. Those two tactics will definitely get us to our predefined goals, but that requires some time. And when it comes to improvement, all those things, it's hard to see improvement in 1 month. It takes time to implement changes and then trend them and observe improvements. So this is all that we have. We're open for more questions, comments, feedback.
Any questions?
No, thank you. It's impressive work.
It really is.
And I love
a lot of great work.
the use of data to drive decisions. And it's impressive. Thank you
very
for
much.
sharing.
Thank you.
Thank you.
Thank you. Okay, let's see. There are no appointments or reappointments being presented. So we'll move to item 4B, the EMS MEC reports. And Dr. Akintoran will present the Soldier Hospital Quality Committee summary for informational purposes and will present the medical staff action items for the committee's consideration.
Thank you. Good morning.
Good morning.
Good morning.
All right. So the first thing that I will be presenting is the report of the credentials. This is our medical staff appointments, appointments and changes, reappointments and changes. And you have the document before you, and there's nothing out of the ordinary there. They're all, it's all in need report. And then if there's any question, usually we'll pause if there's any questions regarding those. Usually they are not. And then the next thing is the highlights from the minutes of the CCH QPS Committee. The minutes of their meeting 2 months prior, that will be in April. And this were presented to the EMS at our meeting this past Tuesday. So I have a little addition to what's up there. So for the quality HR dashboard report, there was a slight decrease in communication with nursing metric, but still higher. It was 70 than higher than the rolling average of about 60. There are ongoing efforts to improve surgical CMI through education and improved documentation. For the mortality, the observed over expected, it did go down to 1.08 from 1.3 for all of 2022. Now, I'll just refer to the report by Dr. Mikairis that it is better. It's going in the right direction for the more recent reporting period. I'm also pleased to report that there was zero hazardous material spills for that for all of 2022. I'm sorry, I think I made a little mistake there. For the hazardous spills for the whole of 2022, there were zero reports of that. Now, regarding pharmacy, in the February to April reporting period, there are some areas of concern with performance below 80%. One of them was dating of multi-dose vials. The second is expired medication that's on the floor. The third is unattended medication that's left around the nursing station on the couch. The goal is that everything should be 95% to 100%. Pharmacy department continues their rounds and education on inpatient wards to improve those numbers. Now, on the slide there, we do see a decrease, 3% decrease in the inpatient orders the pharmacy is filling, but that's also, I had that counterbalance, so improved by the mail orders that are where there is 3% increase. They are doing better at keeping patients out of the hospital, and they are doing better with medication compliance because they are coming to get their prescription filled. On the case management, this is really reports of a great success that in the first quarter, the final denial rate. Now, to kind of explain that a little better, there were 523 admissions, and there are 229 letters from payers where they would need additional information so that the payment can be reprocessed. That effort is going really great, so that we have final denial rate is at 3%, which is much better than the national average rate of 12%. The credit belongs to the team, led by, I think, Dr. Kumapli, Ms. Agomo, and Dr. Botosho. They're doing a great job at that, and that's really bringing in revenue that would otherwise have been lost. Prior to this, the payers, their patients are taken care of here, patients that they insure, and then they send those denials and all that, and there was not as good effort in responding to those. They just get the care for free on the back of Cook County Health. really great. It's a turnaround from what was happening before. For the first quarter of 2023, for discharge dispositions, issues, and delays in care, it was down to 5% in March and down from 15% in February. Now, some areas of improvement. Duplication of PRN for pain medication. We do notice that our OB department is kind of responsible for 28% of those duplicate orders, and the plan is on to work with them to reduce that practice. Insulin being compliance is at 92%, up from 91. The goal is 95%. The HRO readmissions focus is on high utilizing patients, and there are ongoing efforts to provide timely follow-up appointments for patients with heart failure, and I'm sure we are hearing that from different directions in the report by Dr. Mikaitis and Dr. Pierco. Also to improve patient navigation after discharge to prevent readmissions, and our readmission rates, of course, that's going down. I believe in the reporting period, the readmission rates went down from 11% to 8%. And the final one here is again to highlight the success story that we are getting for the sepsis bundle compliance. There's significant improvement in that, as you heard from the other previous speakers. So I will pause for a few moments to see if there's any questions.
Any questions or comments?
None for me.
Okay, well, thank you. There are no action items before the MS committee, and no action items arising from this before you today. Thank you very much.
Thank you, Dr.
Thank you.
Good report. Thank you. Dr. Mark Lofman will present the Provident Hospital Quality Committee summary for informational purposes, and will present the medical staff action items for the committee's consideration on behalf of Dr. Marlon Kirby, President of MEC.
Good morning, Directors. Thank you.
Good morning.
Dr. Kirby's in the OR, and I'm happy I chair the Quality Committee. Always happy to do the report on his behalf. There's several actions from the Credentialing Committee, a variety of providers and physicians and advanced practice providers for both initial and for reappointment that were all recommended without exception. There also are several who moved from provisional to either active or affiliate. Also, I think you may recall that if primary appointments at Stroger, they're an affiliate at Providence, so that's why the affiliate or active category is that way. Those were also recommended without exception, and they're in your packet for your review as well. In terms of the Quality and Patient Safety Committee, updates from May and moving into June, we've highlighted some key areas that you can see here in your slides. In terms of laboratory, the stat testing turnaround time, 92% compliance, so it's an improvement noted there. A few areas of exception that still happen, but by and large, that team is doing a great job of getting that stat turnaround time. Critical result reporting, also at 100%. Finding the use of Tiger Connect has helped with that as well. We're able to reach providers in a timely manner and document that handoff was made. West Nursing continues to work on a variety of initiatives. We put here some highlights from that success. So 0 hospital-acquired or healthcare-associated pressure injuries for the Q1 of 23. 0 central line-associated bloodstream infections noted for 2 years now. And there's not a high number of central lines at Providence, but they do have them and more all the time now. So that's also something we're proud of. Staying on the infection control theme, you can see that C. diff infection, the last case was reported in August of 22. None since then. And again, no central line, no catheter associated or ventilator associated pneumonias for the 2023 so far. Some other highlights from the Quality Committee. Again, all of the teams are asked to reevaluate their annual metrics. I'm looking at is it a regulatory requirement? Does it meet a current patient safety goal? Where's the alignment with the strategic pillars at county? And then making sure there's an aim statement with the who, what, when, and how that will happen. Mr. Brady from quality and other quality leadership are coaching, providing support and some protocols and process to help the teams do this. And this is really helping them begin to stretch a little bit, reach for some quality areas to improve. And I think the teams are really responding to that well, asking questions, looking for help, and providing more and more useful data that's actionable items that we can work on. So those are the highlights from the Med-Exec Committee on our quality of work at Providence. Thank you.
Excellent report, Dr. Wilson.
Yes.
I do have a question. So when we're asking those questions, what materially changes as it relates to what you're focusing on?
What material against it?
What materially change your focus? What materially with your focus changes when you're asking those questions to take you to a different place of focus, I guess?
Yeah, so we're giving them, there's a slide set that has some informational material or background about how to work forward and some examples of a quality project, how to do a plan, do study, act cycle, and that, and we have resources to that too. So we find, people want to do this work, but it's not, they don't necessarily have a degree in quality improvement. So
right.
Providing that coaching tool and standardizing it. So when we see the reports that are coming out, I think historically it's a little perfunctory. It's an administrative task to put your data forward. We're moving out of that mindset with the quality leadership here at Stroger, helping to be more, this is useful information for our department to be using on a day-to-day basis. This is actionable work. It's not a busy work task I have to report out once a month. So I think that culture shift has been very helpful. And it's, again, good support that's being provided. I've watched a significant change over the several years that I've chaired the committee from people, again, feeling like they had this burdensome task to report out these numbers to, really using the data and the tool as a process to truly improve the work. And that's the source of what we always want to see.
Great. Thank you. I appreciate that. Any other questions or comments?
No, thank you.
Thank you, Dr.
Yes.
Okay, so these two reports will be held for a combined motion soon. The June 22nd, 2023 minutes, these were approved by the board at the June meeting, but are being presented for the committee's review and discussion if necessary. Are there any corrections that need to be made to the minutes? Okay, so we'll hold that for a combined motion, which is where we're at now. Item 4D, combined motion. I'd like to entertain the following combined motion to approve the following, approve item 4B, Stroger Hospital Medical Staff appointments, reappointments, and changes. Approve item 4B, Provident Hospital Medical Staff appointments, reappointments, and changes. Accept item 4C, June 22nd meeting minutes. Is there a motion, please?
So moved.
And there is a second, okay. All in favor? Aye.
Aye.
All opposed? All right, so the motion carries. And I do not believe we have any closed meeting items. Okay, so with that, the agenda is exhausted, so I'll declare the meeting adjourned. Thank you for all the great reports today and the work you're doing.
Day's work.